stress. And speaking of stress, Dr. Pawa is here tonight to talk to us about the impact of stress on health during menopause. Thank you for being here, Dr. Pawa. Dr. Nathalie Gamache, a gynecologist who completed a fellowship in menopause back in 2005. She is presently a clinician at Crossroads OBGYN Center in Vancouver, and her specialties include menopause, hormone therapy, sexuality, premenstrual syndrome, premature ovarian failure, and cancer survivorship. She is an assistant professor with the Faculty of Medicine at the University of Ottawa for 10 years, where she collaborated to develop and launch a curriculum at the Faculty of Medicine, which is focused on women's health specifically. Tonight, Dr. Gamache will be talking to us about hormone therapy and the most common gynecological concerns that women have. Our fifth expert tonight is Dr. Jennifer Beecker. Dr. Beecker is a Royal College certified dermatologist who is fully trained and certified in 3 separate medical specialties: dermatology, emergency medicine, and family medicine. In addition to that, she has earned the American Board certification as a dermatologist by the American Board of Dermatology. Dr. Beecker is an active staff at the Ottawa Hospital and is assistant professor at the University of Ottawa. Her range of expertise in dermatology include medical dermatology, skin cancer, as well as cosmetic dermatology. And Dr. Beecker is currently the National Chair Spokesperson for the Canadian Dermatology Association Sun Awareness Program and the Research Director of the Division of Dermatology at the Ottawa Hospital. To top all of these accomplishments, Dr. Beecker also conducts and supervises many research studies that have led to many publications. Tonight, Dr. Beecker will address menopause-related skin concerns. So in terms of how the webinar will go, we will be discussing each topic with the respective expert. And of course, Shirley will be moderating these topics with the experts, and we will be bringing all of your questions to the experts. So don't forget to write your question in the small Q&A icon that you see on your screen. After each section, there will be a 5-minute Q&A session, after which we will move on to the next section. At the end of the webinar, there will be an open Q&A session generally where you can ask all of your questions to all of our experts. And I would like to remind you that at the end of this webinar, you will be receiving a survey. And if you fill that survey, you will have a chance to win a fully equipped Vichy Neovariol gift basket. And without further ado, Shirley, I'm going to pass you the baton and we can start this webinar. Thank you.
Thank you, Nour. Oh my goodness. I'm actually vibrating right now, and it's with excitement because Nour, you and Alexandra and your team at Vichy, we met nearly a year ago and started planning this event tonight, which is just amazing to be here and to see all of the people that have joined us. So thank you for all the work that you've done to get us to the starting line. And I will do my best to take it from here. As Nour mentioned, my name is Shirley and I am a menopause chick. That's how I introduce myself. I'm 53 years old. I live in Port Moody, British Columbia, grew up in Ontario, and my journey to becoming a menopause chick actually started 10 years ago. I was sleep deprived. I was experiencing PMS and anxiety for the first time in my life. And I had brain fog that was debilitating and affecting my ability to run a business and to run a family. And so I did what every other smart, savvy woman would do. I went to my doctor and said, hey, I think I'm experiencing the first signs of menopause. And she looked at me and she looked at my chart and she said, you're 41, you're too young, but here's your options: the birth control pill, sleeping pills, or Prozac. And I was actually really blown away by that because it wasn't at all the answer that I was expecting or the vision that I had for my health at that time. And so I sat there for a minute being really disappointed. And then I quickly switched and I thought, you know, I can't be the only woman in the world that's experiencing this. And that was really the beginning of Menopause Chicks, which is a private online community. You can find us at menopausechickscommunity.com. And our mission is to empower women to navigate perimenopause to menopause and beyond with confidence and ease. And we do that through the engagement, the contribution, and the amazing expertise that healthcare professionals who share our passion for women's health education and our vision come to the table, and they bring their education, their expertise, as well as just, you know, working with women who look like us, who have the same questions as us, who have the same experiences as us. And tonight is an excellent example of that. You are in for a treat. The women that you are about to hear from, the health professionals who have joined us tonight, are leaders in their field and they're leaders in Canada. And so it's our hope that when we end this call tonight, that you are feeling a little bit more confident and have more information so that you can feel informed and then choose the journey that's right for you. Now, the other thing that I do is that I advocate for women and women's midlife health, because there are gaps. And you probably know that because you've taken time out of your schedule to be with us tonight. There are myths, there are misconceptions, and there are gaps in terms of how women access the answers to the questions that they have. I was just reminded yesterday, actually, during another call, about a Harvard Business Review study that came out in 2015 that identified 77% of women have questions about their health. And I think that's really evident in terms of how many of you who have registered for tonight who are or who are watching this replay. 62% of us say that we lack the time to do the adequate research. And again, that's why this is so exciting, because in a couple of hours, we're going to package up the best content that there is for you and your health. 31% of women don't trust online information. Now, keep in mind that stat came out before we were faced with a world pandemic, and we're all consuming our content online. But 35% of women said they don't trust their own doctor. And that's really disappointing. And then I did my own research with Menopause Chicks in 2016. And 70% of women told me that they didn't have anyone to talk to about perimenopause or menopause, or that they would never talk about it with anyone. And I think that's why Nour used the word taboo in her introduction, is that not only are we lacking adequate information and education, but we're also looking to bring this conversation to the forefront and to dispel some of the myths, some of the language that maybe we've inherited generationally. Menopause is not old, hot, tired, bitchy, and fat. It's actually wise and beautiful and confident. And we're at this stage of our lives where we're the smartest that we've ever been. So our mission is to empower you to navigate perimenopause and menopause with confidence and ease. As I mentioned, I am so grateful to Vichy for picking up the baton on that and wanting to host this event for us. And I know that we're going to have a lot of questions. I am going to do our very best to get those questions to our experts as we go, but I am going to ask you that we pose the questions the same way we do in the Menopause Chicks community. So if you can, please state your age, state your stage, so perimenopause or postmenopause, and then tell us where you're from, because that's really going to help the experts in terms of forming their response to you. And if we don't get to your question, or if there are links to share, or you're interested in finding a health professional to add to your team, This Sunday, October 18th, is World Menopause Day. I'm going to host a live event for all of us in the Menopause Chicks community. Come by at 4 p.m. Pacific or 7 p.m. Eastern. I will share those links. I will be your concierge, and any questions that we don't get to in the time that we have tonight will get answered for you on Sunday. So it is my pleasure. I can't even tell you how proud I am of this panel of experts. And I really want to get us started with one of my favorite naturopathic doctors and one of my favorite people, Dr. Cara Dionsio.
Thanks so much, Shirley and Nour. I'm just going to figure out for a second here how to share my screen. Nour, I believe you're going to have to enable the participant screen sharing here.
It's already enabled.
I'm clicking and it's saying host disabled participant screen sharing. Or maybe you need to make me a host.
You are already a host. Give me 1 second. Let me check why it's not working.
Okay.
Maybe she needs to be a panelist.
She is already.
Oh,
everyone is.
Now you're a co-host.
So I think now you should be able to share.
Now we're okay. Yeah.
Yes, you should be able to share.
Okay. Good. Can everyone see that now? Yes. Okay. Well, thank you so much, everybody. It's really a pleasure to be here. And I really want to start by thanking Vichy for acknowledging the importance of supporting women through menopause, the menopause transition and beyond. And I'm really honored to be joining a panel of women's health advocates and female physicians. And thank you for taking the time to be here today. I really believe when women gather, magic happens. And I'm glad that you're here learning with us today. So are you ready? I'm going to take you on a fast and furious ride through menopause. I want you to think about menopause a little differently and even help create a little spark to empower you to find the solutions that are right for you. So hormones through a woman's life can feel like a roller coaster. And, you know, I want to start by directly, like literally looking in the lens and speaking to you who are listening, who might be really struggling. I want you to know I see you and hear you as a women's health focused naturopath. I see thousands of women in my clinic. Some are really thriving, but some are really struggling. And they're saying things to me like, Cara, I just don't feel like myself, or I don't know how to get back on my feet, or I'm not finding the help that I need. And while all transformations have some growing pains, I'm here to tell you that this can look different. Suffering through menopause or puberty or pregnancy or periods is not part of being a woman. There are times of life that we should be able to actually celebrate. And so lately I've actually been thinking about contrasting menopause to pregnancy, because both are major life transitions and both are times of immense hormone change. In pregnancy, we build teams. We have a physician, we have an obstetrician, maybe a midwife or a naturopath or a lactation consultant. We foster good health. We don't drink alcohol. We eat lots of veggies, keep active, take our prenatal vitamins. We create a supportive community, right? We have mom groups and baby groups and play groups, and we may even celebrate. We have baby showers. Now think about menopause. Like, where is that diverse amount of support? And really, I think that's why women are struggling, because the answer isn't found in a 7-minute doctor's visit. It's not in a hormone bottle only, or one skin cream, or changing your diet exclusively. As a naturopath, my central approach is really looking at health in a holistic way and considering all the components that really make up health and trying to help my patients foster that. And we have to get this right. I want to get this right because my mother-in-law, who does not know I've posted a picture of her in a bikini, and my mother, they didn't have this information. But I really want to change this for myself and for you and for my daughter and yours too. So let's meet the cast of your hormones. I tried to make this something you'll remember. So these are the key characters of your hormones that you feel on a daily basis. And in the background, they're actually building health over the long term. So estrogen's been called the Marilyn Monroe of hormones, or the chemical with the cleavage. She helps form curves and breasts at puberty. She grows the uterine lining. She helps the vagina be nice and lubricated and elastic. And she's a goddess. She is a feel-good hormone. She increases neurotransmitters like serotonin and endorphins. But like any good friend, we all need that calming, sensible, level-headed friend. And that's what progesterone is to estrogen. She balances her out a little bit. She's very calming, might help with sleep. And she's good. She wants to make, she maintains the uterine lining to hold a nice little home in order for a baby to burrow, if that should be the case that month. And then we have testosterone. It's not just a male hormone. It gives us our oomph, our motivation, energy. It helps build muscle and us recover from exercise. And along with estrogen, really contributes to our libido, our sex drive. And so the premenopause years are when we're getting those regular patterns of menstrual cycles where the hormones are following a very predictable monthly pattern. I love talking about healthy menstrual cycles. We don't have time today, but I really invite you, if you're in this stage, to really learn about your hormones and what they're doing and how you feel at different parts of your cycle. So here's a nice roadmap to menopause. So menopause is a one-day event. It's defined as the final menstrual period, which we confirm after 12 months of not having a period. On average, it's around the age of 51, usually around sometimes between 40 and 58, but 51 is about the average for natural menopause. Perimenopause is the stage of life or the transition that may be about 4 to 8 years before menopause, in which you're starting to experience changes to your body and to your cycles. So early on, we might just see changes into the character of the menstrual cycle. And then we might start seeing a little bit later changes to the length of the cycle, varying by 7 days or more. And then eventually in later perimenopause, we're going to start seeing skipped periods. And this is a time you want to hold on for the ride. It can be a time of turbulent hormone change. 1 month hormones might be high, another they might be low, and we kind of lose that balance of estrogen. We lose the balance of Marilyn Monroe and June Cleaver. And every woman will experience this differently. You know, we will probably see changes to the periods, like heavier periods or changes to the cycle length, or just the character. You might be getting regular cycles, but as Shirley mentioned, you might be getting, you know, brain fog or insomnia or headaches, mood changes, or I hear this a lot, weight gain despite not changing diet and exercise. I don't have much time today, but I really wanted to talk about heavy periods. It's a really common problem at this stage of the menopause transition. There are lots of solutions, either that I have or I'm often referring to a great gynecologist. And in this stage, iron really plummets. So I really ask you to get your iron tested and really supplement like accordingly, because iron deficiency can really look like a lot of other things and it can make you feel really terrible. And then we're here at menopause, you know, where our hormones do come down and rest at lower levels. So I want to take you through some common things that I see women experience as a result of the hormones kind of finally landing at a lower level. Probably the most iconic that we hear are hot flashes. Over 60 to 80% of women will have hot flashes or night sweats. Medically, we call these vasomotor symptoms. These can last on average 7 to 10 years, and they really can reduce quality of life measures. They'll impact sleep and mood and cognitive function, or just our ability to get through work or our day. And we need to pay attention because some women with more severe hot flashes are more likely to have a subsequent depressed mood. And we also are trying to see in science or in the literature that perhaps hot flashes might be associated with a higher heart and bone health risk. And so there are always options, and you should always know your options. And this is what I walk my patients through, the range of treatment approaches. We're often matching the treatment to the severity of symptoms. So for more mild hot flashes that aren't maybe too bothersome to you, then I'm going to support these foundations, perhaps identifying food triggers like sugar, caffeine, and alcohol. I've used herbal medicine for over a decade quite successfully, so you might want to work with an evidence-based integrative practitioner. And then what we'll learn about next with Dr. Pawa, how stress and anxiety can be a very big trigger, and that's something that it would be great for you to figure out ways to manage your stress levels. And then there are the women who come to me, they're soaking their sheets every night, they can't sleep, they're not functioning, and they're miserable and exhausted. And these are the women that say, Kara, give me the hormones. And I mean, unless there are strong contraindications when that's that severe, it's something that really should be considered. Because hormones, they're the first line approach. They can work very quickly and very effectively. And I know there's a lot of controversy of hormones, which I wish I could get into today. But I want you to be able to find a practitioner who can talk and sort that out for you. Look at what your individual risks are. But my goodness, please ask what the benefits might be too. And even the North American Menopause Society does say that if for women who are under 60 and within that 10-year window from menopause, that the benefits often do outweigh the risks. And this is both for benefits for long-term health protection, but also because you should not have to suffer. You should not accept we don't do hormones anymore. Please find an informed practitioner that can walk you through all of this. And so skin, your vagina needs skincare too. And so just like Vichy acknowledges the importance of skincare around menopause, your vagina wants a skincare regime as well. She's feeling a little left out. And that's because the vagina, vulva, and bladder are all tissues that are sensitive to estrogen. And so as a result of estrogen levels coming down, the vagina can lose this kind of folded texture, lubrication, and elasticity. And this can lead to things like dryness or irritation, painful intercourse, increased urinary frequency, or urinary tract infections. And the key here is that unlike hot flashes, which do tend to get better over time, although I'd argue 7 to 10 years is too long, the vaginal dryness is something that does keep progressing. And so I want you to take care of your vagina. And while we learn about awesome skincare today, you might want to think of some things that will help in this respect as well. So vaginal lubricants are designed just for sexual play. That's what those are for. Whereas we have something called vaginal moisturizers, which often have something called hyaluronic acid. So just like some great Vichy products, which help retain moisture, the vaginal moisturizers can really do a great job for kind of daily vaginal care. Vaginal estrogen is very effective. It's local, low dose, and very safe for a lot of women. So talk to your doctor about that. Get an awesome pelvic physio on your team. They are honestly rock stars, and they can help you so much, in particular if you're having bladder issues or prolapse issues. And if you want to get fancy, there's some new laser therapies that are going around as well. So sleep is something that definitely takes a hit in the menopause transition. Most often I see women who are having trouble staying asleep. And the sleep does correlate with lower estrogen levels. It does correlate well with more hot flashes causing more disturbed sleep. And in fact, though, anxiety seems to be the strongest predictor of poor sleep quality. So again, listen up to our next speaker. Hormone therapy can help, especially oral progesterone is quite helpful. Managing stress. I always say sleep is created in the day. So the better you can manage stress and anxiety in the day, we tend to see better sleep. Physical activity, exercise is important. I see lots of problems with blood sugar. So when blood sugar dips in the middle of the night, that can release cortisol and wake us up. Caffeine, oh, sweet caffeine. It has a 12-hour half-life, so you might want to check your coffee after lunch. And then lots of sleep hygiene, especially with technology. Brain changes, like Shirley was talking about. So cognition encompasses things like attention, memory, concentration. And I'll just hear my patients say, Kara, my brain just is not working like it used to. And these are mild temporary cognitive changes that are not, they're falling short of dementia or Alzheimer's, although we need to screen for those. These seem to be transient, and especially around the late perimenopause, early menopause transition. There might be benefit for hormone therapy, although later on it seems to not, it actually might have negative effects. And lifestyle therapies, so social connections, maintaining those, physical and mental activity. Take a look at the MIND diet, really great big study done in the States, looking at a Mediterranean type diet that actually showed a 50% reduction in future dementia or Alzheimer's for people who followed that diet mostly for about 5 to 10 years. Heart health is brain health. And then my favorite herb, actually, I just studied for an exam and I took some bacopa. So that's an evidence-based herb for memory. So take care of your brain through your whole life, but you're gonna see a little bump here around this time. It's really important that we're screening and acknowledging mental health during this transition. There's a higher risk even in women who've never experienced depression. And this was a huge stat. We may have a 14 times higher risk during the 24 months surrounding the final menstrual period. Hormone therapy, though, has a window of opportunity with transdermal or topical estrogen that might have antidepressant effects similar to that of antidepressants, or maybe a synergistic effect that estrogen might help those work better. And again, foster good mental health through your life. You might need a great psychotherapist or counselor on your team. Nutrition, exercise. Do you see me repeating some things here? I love St. John's wort, and I love community for fostering good mental health. Joint pain, again, I'm not talking about osteoarthritis or rheumatoid arthritis, just general joint pain and stiffness can creep in for about half of women at this transition. And again, it's related to estrogen, which helps the structure and function of muscles, tendons, ligaments, and directly helps collagen and connective tissue, which is why it's also important for our skin. Again, managing weight, lots of exercise, glucosamine omega-3 or curcumin for the more natural approaches. Hormone therapy can be helpful, perhaps not exclusively for this. And then we might need some anti-inflammatories, whether those be herbal or prescription. And this one is dear to my heart. I consult for a bone program, and I can tell you those women wish they knew they were at risk before they were diagnosed with osteoporosis. And the problem here is that we don't screen for bone density till the age of 65 in North America. And that's a problem when menopause is over a decade earlier. And so we might not be employing therapies that would be effective. So I want to invite you to look at the risk factors for osteoporosis, things like a parent with a fracture or osteoporosis themselves, certain medications through life, perhaps gut issues like Crohn's or colitis where you can't absorb nutrients as well, or perhaps if you're finer framed or under 125 pounds, talk to your doctor to see if an earlier scan is indicated for you, because hormone therapy is one thing that might reduce risk of fractures by about 30%. And then we also want to make sure through our whole life we're fostering lots of resistance exercise and getting sufficient levels of calcium and D so that we're building lots of good bone. And then finally, heart disease. Women are protected from their hormones from heart disease. We have lower risk than men up till menopause. And then at menopause, that risk, we lose that. So our risk, it becomes more equivalent to men. And so the key here that I want you to think about is building a healthy cardiovascular system leading up to menopause so that we have that buffer, because we do see a bump up effect of cholesterol, belly fat, blood sugar regulation, and even hypertension or high blood pressure. So I want to end today by giving you 2 action steps. Right now, I invite you to write down 3 things you can start doing. You've heard me talk about building strong foundations of health today. I want you to write down 3 things you can do that are sustainable. Don't do a crazy diet. Don't join CrossFit. Maybe it's a small nutrition goal. We all know something we can change. Maybe it's calling a friend and committing to a walk 3 times a week. Maybe it's something we need to do to reduce stress, or adding in something that adds joy and connection and purpose in our lives. I also want you to think about who you might need on your healthcare team to navigate perimenopause and menopause. It's going to be different for all of us. And I'm looking forward to hearing from our other experts today. Menopause is the autumn of our lives, and while we have lots of twists and turns on the journey, it really can be full of bright, vibrant colors, and I hope you've learned something that might help you on your journey today. And so thanks for taking a wild hormonal ride with me.
Thank you, Dr. Kara. Oh my goodness. Okay, what a great way to kick this off. And we do have quite a few questions in the queue. So I think we should start by maybe clarifying a definition. There are a number of women on the call, Dr. Kara, who have had a hysterectomy.
Sure.
And so let's define medically induced menopause as well.
Sure, and it was in there. I just skipped over it, unfortunately. Okay. So yes, so menopause can be earlier due to medically induced reasons, which could be a hysterectomy, including taking the ovaries out, or in some women who've had cancer therapy, so maybe radiation or chemotherapy, that might induce an earlier menopause. And yes, that takes kind of the guesswork out. And after that, if we realize it's impacted ovarian hormone production, then they would be considered in menopause.
Okay. We often hear from women who have had their uterus removed and they want to know when they've reached menopause.
Yeah. And that's harder, right? Because the ovaries are still there. They can still be making their hormones, but we don't have the period as a marker. So that one's a little difficult. That's a little bit harder. That's where I might be testing some hormones just to get a better gauge.
Right. Okay. So hopefully that clears that up. That was an anonymous attendee. We have a question from another anonymous participant about our health team. And I'm glad that you included that in your presentation. So many Canadians, many people in the world, I would imagine, are not attached to a family doctor. Mm-hmm. Are there recommendations that you might have for building your health team if that's the case?
So what I've seen actually out of COVID, which is really interesting, I mean, I live in a rural area where there's less physicians. And so people move here and might not have a doctor. They're on the list for 1, 2, or 3 years. But what I've loved actually is through COVID, there's been some changes to telemedicine, and those patients I have, we've actually had more access to healthcare. And so maybe those patients who don't have that family physician could use a more virtual approach to finding a family doctor. And then a naturopath is not a primary care, like it's not a good substitute, but sometimes I'm doing that and as a good sounding board, and I'll know when I can refer. And again, I'm sometimes using those virtual platforms to have access to a doctor so that we can further refer on to specialists when needed.
Yeah, absolutely. Absolutely. Okay. Sharon is 59. She's from Ottawa, and she has a specific question around hormone therapy, but it comes up quite a lot in the Menopause Chicks community, and that is oral progesterone versus transdermal. And we've all heard that oral is better.
Yes. So when we're talking about hormone replacement therapy, and if we're giving estrogen, So the estrogen could be oral or transdermal through the skin. If you have a uterus, you have to be on progesterone. And remember, I was talking how progesterone's the balance. Well, progesterone actually protects the lining of the uterus when we are also giving estrogen. And to protect the lining of the uterus adequately, we need to be giving progesterone in indicated ways. So that is only going to be oral progesterone or vaginal progesterone, or in some cases an IUD. The transdermal progesterone is not adequate enough to protect the lining of the uterus from estrogen.
Good, thank you. And hopefully that answered your question, Sharon. We have another question about the length of time on being on hormone replacement therapy. So should someone be talking to their physician about stopping hormone therapy?
So that is totally individual risk benefit analysis, right? And that's where individualized care comes from. You know, if there's persistent hot flashes or we have big risk to bone health, there are times when we can continue that. And for other women, we can trial going off of it, and that might be okay as well. So that's totally a risk benefit that is very specific to your health specifically.
Yeah. Okay, thank you. Kathy is 51 and she has a question about irregular bleeding. And you mentioned that in your presentation. Her experience is a little bit different. In perimenopause or before perimenopause, she was irregular, and now she's in perimenopause and her periods have become regular. However, she's experiencing some spotting, some sleep disruption, some mood changes. Any comments on that?
Yeah, welcome to the ride of perimenopause. I'm wondering, when periods are irregular kind of earlier on, sometimes we're thinking of things like PCOS, which actually then can normalize, like closer to menopause, the hormone levels kind of level out a bit and can become more regular. So it's hard to know without the specifics there. And I can't remember the other things. There was some spotting.
Spotting, mood changes, sleep disruption.
Yeah, so those are sounding like lower progesterone signs to me. So spotting, we're going to see lower progesterone and especially the impacts of sleep. And that's just because the ovaries getting a little tired, maybe not ovulating or not maybe making as much progesterone. And so that might be, that perimenopausal time might be a great time to support progesterone levels.
Oh my goodness, we've already gone over our time for Q&A. I can't believe it. I do want to thank you, Dr. Kara, and especially for pointing out the investment opportunity that we have in this phase of life, because I think there's so much information that's shared around perimenopause and menopause about treating the here and now and tackling specific symptoms. And you've really given us a lot to think about in terms of our brain health and our heart health and our bone health. So thank you for doing that.
Thank you, everybody.
Okay. Our next presenter is Dr. Bal Pawa, and I don't see Bal yet, but hopefully there she is sharing her screen. As Nour mentioned, Bal is an integrated physician and a pharmacist and a women's health advocate and an author and a Harvard-trained mind-body expert. So we are in for treat number 2. Unmute.
Thank you, Shirley, and thank you to Vichy for pioneering this. And I hope this continues to be advocates for women's health. That's what you two are doing, and bringing the collaboration of all the panelists and getting good information out there. So I applaud you. Thank you for doing that. So I'm going to share my screen, and hopefully you can all just see that shortly. Let's see. Is that coming up? No, not yet.
Not yet.
Okay. This is the one I've got up. No, it's not showing up. Okay, here we go. There it is.
There we go.
Does that work?
Yep.
Okay, so a little bit about myself. I just am a physician, but I got into women's health sort of serendipitously and stress at the same time. So stress is very pervasive, and I was doing a lot of deliveries, and I happened to have a situation where I had a car accident, which made me a patient. And as a patient navigating my journey, I had to think of other ways of being a physician that didn't involve delivering babies because I damaged my shoulder. And that's how I ended up at Harvard Medical School to do some counseling. What I didn't know was that experience not just transformed my life, but helped me to transform myself professionally. And I came back to Vancouver and co-founded the West Coast Women's Clinic. So the last 20 years, we are just focused on hormone health with an integrative approach. And what I can tell you is when I first opened the clinic, we called it West Coast Menopause Clinic. But about a year into the program, we realized, hey, it's not just estrogen and progesterone. And as Dr. Kara mentioned as well, we have to look at the other hormones. So what I'm going to talk to you about tonight is the symphony of hormones and how hormones talk to each other. And I really underestimated the role of cortisol, which is your stress hormone, on women's health. So that compelled me in the last 20 years, as I watched 75% of the symptoms that walked into my office. Of course, there was the hot flashes, the vaginal dryness, and the mood swings. But as I started to listen to women, I started connecting the dots and seeing that stress played a huge role. And then I started to do more and more research on what does cortisol actually do to our female reproductive system, and how does the whole system play out when it comes to symptoms.
Dr.
So,
Pawa,
yeah.
would you mind going into full presentation mode if
Oh, sure. Okay.
Thank you.
Here. Is that better? So the first thing we should talk about, so Dr. Kara gave you the wonderful background on estrogen, progesterone, but what you also need to learn today is what does cortisol do and what is stress? The stress can be acute or chronic. So acute would be you're driving along and suddenly a deer jumps out in front of you and suddenly your heart rate goes up, your blood pressure goes up, you're sweating. And that's called the fight flight. So many of you may be familiar with that, the fight flight reaction. And our body is very used to doing some acute adjustments for stress. And we were designed to deal with stress. That's a normal thing. But then when stress becomes chronic, it becomes a problem. But stress can be caused by emotional factors, physical factors, such as chronic pain. A lot of women live with chronic pain. If you're exposed to a lot of chemicals, that can cause stress in your body. Infections, such as the COVID virus, is very stressful to the body. And thinking about getting the COVID virus is the emotional stress, but the actual infection can be a stress to the body. And cortisol is important because it helps us to fight that stress. And it keeps us safe. So adrenaline and cortisol are made by your adrenal glands, and they keep us safe. So when the stress response becomes chronic and you're exposed to it, so if there are months and months and years of cortisol and adrenaline, your body is not used to that. That's what takes a toll on your body, and cortisol starts to wreak havoc with our biological systems. And that's when we see some of these symptoms appear. So you look at yourself and do a little assessment and say, well, how does stress show up in my body? Some people complain of muscle tension, some of migraines, some of insomnia, mood disturbance, heartburn, high blood pressure, low libido. And the list goes on. And as I said, astonishing 75% of the symptoms that present to a GP's office, when we really dissect it and go back and look at the etiology or what's causing it, it is attributed to too much cortisol and adrenaline. And it affects women's hormones as well. So a lot of women come in with insomnia. That seems to be a very common symptom. Anxiety and depression, also very common around menopause. And estrogen and progesterone are also what we call neuromodulators. They affect our mood. They affect the levels of serotonin in our brain. Sometimes women show up with high blood pressure, poor focus and memory, gut issues. And I see a greater incidence of more dramatic symptoms or remarkable symptoms of PMS or menstrual migraines, or a condition called PMDD, which is premenstrual dysphoric disorder. And so a lot of women show up with that, or their partners might call our clinic and say, please see my wife, because for 2 weeks out of the month, she is just unbearable, and we have to start marking the calendar. So it becomes quite a problem, not just for her subjectively, but those around her also start noticing objectively that she's having severe mood swings. And when you have chronic stress, it impacts our gut. So when we have chronic stress, it might show up as immune things, food allergies. It might show up as autoimmune diseases. And in fact, autoimmune diseases are more prevalent in women than in men. And it's becoming a disease that's taking over some of the statistics and rivaling some of the chronic diseases such as diabetes and arthritis. Breathing problems are also a problem. The issue in medical, the model that we know, and I'm a pharmacist and I'm a medical doctor, but what I see is that our system is set up to just treat a symptom. So you have heartburn, you take a medication. You're depressed, here's a medication. And so doctors are overburdened. Our system is overburdened with patient care. As you say, it's hard to find even a medical doctor to get an appointment. So we often end up medicating with intervention. So women will come into the clinic and they're already on antidepressants, painkillers, sleeping pills, or anti-anxiety pills by the time I see them. And with this COVID crisis, I see a differential in men and women. I see women paying a higher price. They're often trying to work from home, tutoring their children. There's a lot of financial uncertainty right now. And then, of course, they're worried about their own health, or their children are going to school and thinking little Johnny's going to bring this disease back to grandma who's living with us. So there's a lot of stress right now, but overall stress is pervasive and higher in women. And there is a pressure to perform as well as deadlines to meet. All of that combined is called a cumulative stress load. And it works on the same system as the fight-flight response. So our primitive brain, where stress is processed, has not evolved. While we have a really big frontal cortex, our primitive brain that deals with stress cannot tell the difference between a saber-toothed tiger, like you see in the picture here, or perceived stress of financial uncertainty or losing your job or getting sick. So there's no discernment from that point of view. So the big message I want you all to remember tonight is that we have a little motor. Think of it as a motor. The autonomic nervous system is a fairly complex system of hormones and nerves, and usually medical doctors and health practitioners and nurses they know about this, but it's a fairly complex system and it's never really been brought to the forefront. But I made it my passion project to talk about this because it's so important. And the autonomic nervous system is located in the brainstem, but it includes your hypothalamus, your pituitary, and it is connected to your adrenal glands, which are located on top of your kidneys. So when your brain sees something stressful, within seconds, you can push out some cortisol, adrenaline, and you can fight or flight. So it's like you just pressed on the gas. So think of this motor and stress causing you to step on the gas. So the motor revs up. Now, most of us default to stress. We usually live in a lot of fear and uncertainty, and our brain learns and habituates and gets conditioned to living in stress. So then if you analyze some of the hormone pathways, you'll see a lot more cortisol and adrenaline. And you become almost as if the gas pedal gets stuck. What we don't realize is the autonomic nervous system has a set of brakes too. And so the first thing I wanted you to learn tonight is about this autonomic nervous system. And the second thing is that it has a set of brakes, and you can learn to put those brakes on. And it's through some techniques that I'm going to show you that you can learn to put the brakes on, turn off the cortisol. And the reason that's important is if cortisol and adrenaline are on all the time, it's not just wreaking havoc with your tissues, it's feeding down to your ovarian tissue as well. The ovaries have what we call the hypothalamic pituitary ovarian axis. So the cortisol, which is your stress hormone, feeds down to the ovarian axis. Cortisol allows things to not function properly. So what cortisol is doing is it down-regulates some of the receptors so that your progesterone doesn't attach properly, doesn't work as well. It eventually depletes your progesterone as well. If you look at the biochemistry of hormones, if you're under stress all the time, the biggest hormone that gets depleted is progesterone. So what women complain of, how does that show up in the body? A lot more PMS, mood swings, spotting, bleeding, heavy periods, hot flashes. So the 2 weeks before the cycle seem to be the worst. Some women get severe mood swings. So the hormone symphony is equally important, not just your estrogen, progesterone, but what else is going on in your body, because estrogen, progesterone are modulated by cortisol, but also insulin or DHEA and thyroid. So all of these hormones talk to each other, and it's important to keep our body balanced. Our body is not just a sum of its parts. It's a beautiful, holistic, integrated system that can work very well if we learn how to do it. So the effects of cortisol on hormones, as I'm showing in this diagram, is that cortisol is like a big bully on the block. It's called a primary survival hormone. If I removed someone's adrenal glands, they wouldn't survive. You cannot live without cortisol. But if you take out someone's ovaries, the woman is uncomfortable. She's probably going to have some other quality of life issues, but she survives. So in other words, a lot of the other hormones are secondary. You can survive without them, or you can live, but maybe the quality of life's not great, but you cannot live without cortisol. And because of this primary mechanism of survival, it's called a survival hormone, your body will get signals from the brain when you're under stress. Make cortisol, make cortisol. So it starts pushing on the adrenal gland to make cortisol and say, well, let's forget about our progesterone. That's just a calming hormone. That one helps our moods, or it helps me to sleep. So let's siphon off some of the progesterone because they look very similar. I'm a pharmacist, and I can tell you that the compound, the molecule cortisol and the molecule of progesterone look very similar. And so they'll pull in some of the biochemical molecules from the ovary and deplete the progesterone. And that's the big connection right there. So as you can see, the woman gets set up into a vicious cycle. So stress, stress, stress first, and then that puts out your cortisol. The cortisol then decreases the estrogen and progesterone action by blocking the receptors. The woman starts saying, well, my moods are worse. I'm more anxious. I'm worrying. I'm getting more depressed. That causes even more cortisol to be produced. And then eventually the adrenals become what we call hypoadrenic. They're producing less amounts of cortisol. So they have to now pull in all the resources. And that's when the progesterone depletion begins on the ovarian level because of the cortisol demand. That puts an additional stress on the body, and around we go. So we have to break this cycle. And I teach women that let's fix what's broken rather than throwing pills at it. Let's go back and fix that nervous system, because that's where it begins. Our mind is connected to the nervous system. Our thoughts at every moment are feeding into the autonomic nervous system, our motor. And at every thought, your motor is either getting revved up more or very rarely you're putting the brakes on. So be careful and be aware of the thoughts that you're thinking, because there is a biological component here. Now, what can we do about this? I have 15 minutes to give you this crash course on stress and hormones. So I tried to cram everything in, but I want you to have actionable tools, because if we don't do something, what I'm seeing, there was a recent medical journal, 34% increase in antidepressants, sleeping pills, and anti-anxiety pills just in the last 6 months. And so women are getting put on these drugs, and those, sometimes when you have severe depression and severe anxiety, of course you need drugs, but there's a side effect to almost every medication. So rather than looking at interventions, we want to create some sustainable tools that you can take home. So I've summarized this into something called a REFRAME toolkit for optimizing your hormones. So I'll go through this briefly. How am I doing for time, Shirley? Okay, so the first R in reframe, I love that word, because you can just step back, take a deep breath and say, okay, how do I show up? How do I look at this differently? And that's a way to reframe. So the R is for reset your nervous system. And there's 3 simple tips to reset your nervous system. Take some deep controlled breaths in through your nose, inhale through your nose, hold for 5 seconds, and then exhale through your mouth. So that's a very powerful way just to reset your nervous system. I call it BMW, like a car, BMW. So breath, mindful meditation, and repetition of a word. So when you do your deep breathing and you make your mind very calm and just focus on your breath and use a word, you could use a word, amen, om, whatever resonates with you. Those 3 things together turn on the brakes. So earlier I talked about your autonomic nervous system and it's always revved up with the gas on. Well, this is a good way to put the brakes on, BMW. So you'll remember that. E is for exercise, which we all know exercise is good for you, but exercise actually burns off cortisol and adrenaline and increases your serotonin levels. So it helps with memory and mood. F is for food. And when I look at women, I ask them, I said, look, what are you eating? What was your dinner last night? And she said, well, I was really stressed out. I came home from work and I just, that chocolate cake had my name on it. I went right to the fridge and there I was. And I knew I didn't want to eat that chocolate cake, but I did. So when your mind is stressed out, you will make poor choices for food. You will sleep worse. Your insomnia is going to be worse, right? Anxiety. And you won't exercise because you'll tend to sit in front of the TV to get some soothing by escaping into Netflix. So remember that a calm mind is absolutely essential if you want to choose good food, choose exercise, or sleep better. Now the R is for reset. Rest. So the first R was reset. The second R is rest. And what I mean by rest is avoiding too much time with technology. What we found is that there was a study done at the Cleveland Clinic. Whenever the phone dings, our heart rate actually goes up. We sweat a little more and our blood pressure goes up slightly. So every time that phone dings, we are wreaking havoc with our nervous system. So unplug from your phone for a couple of hours, go and sit in nature, forest bathe, do some deep breathing, do something creative. And a lot of women find that when they rest, they just get recharged because it helps to rejuvenate. So the fight or flight reaction is one end, rest and repair is the other end. So when you want to put the brakes on, do your deep breathing, take some time away from technology and rest and repair your nervous system so you can turn off cortisol and then also help your other hormone symphony. The A is for assess. Assess your inner dialogue. And when women become more aware of what they're thinking, awareness is the agent of change. I found that when I just brought the awareness to women and said, look, connect your thought, your emotional state is reflected in your physical state. And I want you to connect the dots. When you were really stressed, what were the choices you made? And what were the symptoms you were experiencing? And so when women start to connect the dots and integrate their mind and body, they see that the awareness and the assessment of their inner dialogue holds the key to change. The M is for mindset. So what we're ultimately wanting to do is teach you how to have a mindset of resilience. So if you have a mindset that is strong, it's based in trust, not in fear, you've calmed your mind, you're able to step back and respond instead of react. So react would be just a gut reaction. You don't have to think about it. Stress is automatic. But when you respond, that is a very deliberate response to a situation. You take a breath and you take a measured approach, and your hormones will thank you for that. So the first 6 steps are basically just to help you to prevent hormonal imbalances. And the last is E. As Kara said, you need to be examined and evaluated. If your symptoms are severe, you may need hormone therapy. If you're at perimenopause, you may need some luteal phase, or the last 2 weeks, you might need progesterone. If you're in menopause, there's a higher incidence of depression at menopause. Certainly, that is concluded by many different studies. And if you need to have antidepressants along with some hormone therapy, that's okay. My focus today is to teach you the connection between the mind, the body, the cortisol, and how it impacts your hormones, and how you can take charge of your health. So remember the take-home message: women who have healthy adrenal glands, who have a robust, what we call a robust reaction to stress. They haven't had a multitude of factors on their stress hormones. They have an easier time during perimenopause and menopause. The adrenals also manufacture another hormone called DHEA. And when normally you would go through menopause, if you have robust adrenals, your DHEA is your hormone of longevity. It can actually turn into estrogen and progesterone. So if you have healthy adrenals, your DHEA can take over, and that will ease your transition through menopause. And when you're under a lot of stress, that causes a decrease in DHEA levels and even low testosterone levels as well. So hormones work in a symphony. Do not underestimate the role of cortisol and stress on your female hormones. And you might have to become more aware to see how stress shows up in your body. But once you become aware, learn to connect the dots. And I want you all to know that, you're not passive spectators. You hold a lot of power. And once you take back your power, you reset your nervous system, restore your health, and reclaim your health by getting educated, by learning from people who are passionate and have expertise in the area. You are taking a step in the right direction. So good luck with your health, and thank you all for being here tonight. And thank you again to Vichy for sponsoring this event.
Thanks, Dr. Pawa. We have some questions for you. I do want to thank you personally, because when I met you, my foot was firmly planted on the gas pedal. And I think, like probably a lot of the other women who have joined us tonight, I didn't even know what the words cortisol or adrenals meant at that point, and certainly not the connection that you were able to draw for us tonight. Do you want to stop sharing your screen, Val, and then we can get some questions going? Our first question is actually about hair loss. It's from Pawa, who's age 55, and she would like to know, is stress a root cause of hair loss?
Is my screen finished sharing?
Yeah, no.
No. Okay. So I'm not sure how to get back there, but I'll just keep going for now and then figure that out later. Stress is, I did a talk on hair loss, and of course, ferritin and low thyroid and low estrogen hormones have a huge role to play with hair loss. Stress can cause hair loss. Usually a very traumatic event happens and women notice about 2 or 3 months later that they lose hair. And such as childbirth, for example, that's a change in hormones and also a stress to the body. And then 2 or 3 months later, they lose hair. Or if you lose a job or you've gone through a very difficult divorce, 2 or 3 months later, the stress levels can contribute to some hair loss as well. But when you're having hair loss and you're in perimenopause or menopause, you might have to do, I think the dermatologist will speak to this, you might have to do a full workup and look at other things, androgenic hair loss and other causes as well. But stress certainly contributes.
Thank you. Casey, who's 53, has a question about waking in the middle of the night. And she's specifically curious about diet changes that might help her with that.
Diet changes that help her with
waking in the middle of the night.
Oh, okay. So sometimes when you wake up in the middle of the night, if it's 3 or 4 in the morning, usually it's a surge of cortisol. So we give foods that are very calming, things like chamomile tea, lavender oil rubbed on your temples. There are some very natural ways, and I'm sure Dr. Kara will know those, but there are certain foods that can also help. So don't have high sugar or high chocolate or high carb foods. You want to have foods like nuts or seed butters or seed hummus with some olive oil and some vegetables, because that will hold the blood sugar throughout the night. Something with protein in it and complex carbs will hold you throughout the night. And also doing a lot of meditation or what we call sleep hygiene at night helps, because then your nervous system is much more calm. And in the book, I talk about how you have to change the dialogue in here. A lot of women get stressed about going to sleep. They say, well, I'm going to wake up tomorrow and it's going to be a bad day. I'm going to be so tired. And so sometimes we become our own worst enemy because of the inner dialogue. So it's really important to calm the mind down, do some deep breathing, control breathing, and possibly have some good protein snacks at night. And that should help. And there are some herbs that calm down the nervous system as well, such as ashwagandha. But again, it's better to work with a practitioner before you venture out into that world.
That's a great answer. And actually, Sandra had that question too. She's 50 and she wanted to know about supplementing to support your adrenal health.
Yeah, on a program like this, we would want to ask a lot more questions. I don't know what other medication you're on. Right. What, if you have kidney failure, liver problems. So it's really difficult to make specific recommendations, but certainly there are many things. There are medications too, but before you go to medication, I always try some of the natural dietary and mind-body things that would work first. And if that doesn't work, then I reach for stronger. So I would have to know a lot more information if I was to make a specific recommendation.
But it's worth asking your healthcare provider or your integrative pharmacist for recommendations.
Yes.
Yeah. So we've talked a lot about how, this subject is like a Rubik's Cube. Everything is kind of connected. So Patricia is 51 and she says severe hot flashes are stressful. So is it my stress causing the hot flashes, or is it the hot flashes causing the stress?
That's a great question. And it's actually both. So there's a very narrow zone in our, we have a thermostat in our brain called the hypothalamus, and it regulates body temperature, but it's affected by many things. It's affected by your stress levels, so adrenaline and cortisol. It's affected by estrogen, progesterone, your thyroid hormone, certain foods like alcohol, caffeine, spicy foods. So that thermostat is affected by many things. But you will notice that when you're stressed, you will have more hot flashes. And usually if you're waking up at night with night sweats and hot flashes at night, then that is likely cortisol and adrenaline. And if you're having them more during the day, usually it's a deficiency. If you're in menopause or perimenopause, it could be a female hormone deficiency. But the night ones, I find they're well controlled with some of the techniques that I mentioned for relaxation or certain herbs that help with relaxation as well.
That's awesome. Thank you so much. We just like killed 6 minutes right there. So I've got more questions for you. We're going to keep you around till the end. And now we're going to move on to our gynecologist on the panel, who is Dr. Nathalie Gamache. Thank you so much for joining us, Dr. Gamache.
Oh, it is an absolute pleasure. I want to adopt you all and take you home. I'm so enjoying this. It's fabulous. Some of the best lectures I've ever heard, and I'm going to fess up and divulge something in a few moments. I'm going to
share your screen.
Attempt to share my screen. And ooh, look at that.
Oh,
and
wow.
I'm even going to go and see if I can optimize this slideshow. Let's do this and go from beginning, present, online. Nope. Oh, yes. So I changed the order a little bit. Don't panic. We're going to change a mode a little bit here, but I'll go full circle, and you're basically going to get a 15-minute crash consultation with the gynecologist, who just happened to be a menopause specialist as well. So I hope you enjoy the ride and you have some tough questions for me at the end. On the 18th of July, 2002, we were in North America submitted to what I refer to as the nuclear explosion of menopausal proportion. This was actually the date that a study called the Women's Health Initiative was published in the United States, expedited, by the way, that basically changed the entire course of menopause, hormone therapy, and definitely our knowledge base in North America again, and I'm going to keep on stressing that. This study was basically, I'm very commonly asked when I intend to stop talking about the Women's Health Initiative, and my very quick answer is never, because if we don't go back to understand where a lot of what we are arguing about, and I mean this in a friendly way, and having discussion and challenges around the care of peri and menopausal women, there is an origin to all of this. And the day before the study was published, all was calm in the world and had been for approximately 70 years. So the Women's Health Initiative, very quickly, I've always joked a little bit that my son, who was 12 when this was published, would have been able to look at the details of the protocol very quickly if it had been explained to him in very simple way, and decide on the spot that something very, very wrong was going to happen at the end of that study. And very quickly, because it's important that you understand, because this is actually the foundation of where we've ended up in the last 18 years with a lot of frustration, and I absolutely appreciate, is very much the fact that they had to hurry up to recruit enough women to matter in the number of numbers. And the objective very quickly was basically to put some validation to the fact that for 70 years of hormone therapy prior to the study, there had been some observation fairly strongly that suggested that women on hormone therapy actually lived healthier for longer in their lives. So a team of researchers was basically given a huge grant to go ahead and do a very sturdy study that was basically intended for 8 years, that was going to recruit 16,000 women and follow them, half of them on a placebo, which means basically they think they're taking hormones, but it's not filled with any hormonal substance. And the other group is taking the hormones Neither of them nor the research group knows who is whom, and they're going to be followed not for efficacy. We had known about the efficacy of hormone therapy for all those decades before, but for the positive or negative or neutral impact on health. Because big studies cost a lot of money, and they were basically being challenged to recruit the perfect group they had targeted, which were women in the first 10 years of their menopause, still young and in good health. And they were struggling to achieve the numbers to launch the study financially finally, and they basically made a decision to open what I call the floodgate to this day of women who should have never been recruited into the study, and hence the first issue they ran into. So they ended up recruiting women who were over 60 up to the age of 79. And if you look at the demographic of the group that was selected at the end, they basically incorporated 33% of women who already had hypertension. In the group, they already had 7% of women who had either had a heart attack, a stroke, or some huge issues with blood clotting. They had some 11% of women who were 1 pack a day smoker. All in all, not your ideal recruitment group for a study to look blindly at women and whether they do well or not on hormone therapy regarding health in the long term. The second part that failed the study in women big time after it was published is the fact that despite inviting in women in a 30-year age group, they forgot to stratify the group at the end when they analyzed all of this data. So instead of looking at women initially included in the study from 50 to 59, and then 60 to 69, 70 to 79, they looked at the entire group. And at the very end, on the day of the publication, and this information was actually leaked to the media before the study was published, they actually discovered or published that all in all, in the 8,000 women more or less on either side, one group on hormone therapy and the other one not on hormone therapy, the control group, that there had been an excess of 7 women overall who had developed a heart attack over the regular group not on hormone, which was 30. So 30 on one side, 37 on the other. And the number of women with breast cancer was 30 on one side, not on hormones, and 38 on the group treated with hormones. And that is basically the truth and nothing but the truth of the results that caused that nuclear explosion on that day. And I absolutely agree with everyone that there was an excess in number and that we should not be ignoring this. But what happened after this is the whole world basically started looking at North America, because this was very much a North American study. Europe continued with their different hormone therapy approach. They had been doing things very differently, and we'll get back to this in a moment. But they were staring at us wondering where these studies were coming from, why we had gotten these numbers, how come things got to look so scary in North America when they were not finding anything like this in Europe. And basically it took 5 years in the entire world to put pressure on the group for them to reanalyze the same group of data in 2007, where they finally ended up stratifying the group and dividing them in 3 pies, 3 slices of the 50 to 59, 60 and above, 70 and above, where they eventually clearly discovered that the excess of heart disease and the excess of breast cancer were strictly in the group of women over the age of 70. And not only that, they were also strictly in the group of women who were over the age of 70, who still had a uterus and had to be on a progestin that is as old as the planet that we barely use anymore. And that became the culprit, but it never, unfortunately, made the front page of the newspaper because the bad news were already on the front page, and it's very difficult to undo that. What ended up happening when they reanalyzed it is they also discovered that the target group initially, the women 50 to 59 or within 10 years of their own menopause, still in good health, it truly had a protective aspect to hormone therapy, which made them have 30% less breast cancer and 30% less heart disease than the women who had not been taking hormone therapy for those 5 years. And I have to state that these were actually the good old hormones that we have now turned against, that had been prescribed in North America since 1941, known under the name of Premarin and Provera. And even though we had decided or had a movement basically to discard those toxic hormones for the 5 years before the reanalysis, it actually turned out that on those very hormones, the young women in the study had true protection against these two very worrisome medical conditions that women are concerned about. So this is what launched us into scurrying under our desks, becoming very scared of hormone therapy, having women reading the news, having doctors flipping the same papers, being told over and over again that we should never prescribe hormone therapy again because we were killing women, where for the 70 years before that, we had happily been prescribing hormone therapy, no questions asked, until women passed away from something else without ever questioning whether or not they should stop or not. So there's a big event in North America in our lives that basically, in my opinion, has triggered the or mistrust of the medical establishment rightfully. This was one of the most horrible studies that was ever done and published, not just in the world of women in menopause, but in the entire world of medicine. And 18 years later, we are still not done trying to swim back to the surface. So what it's created basically, and this is where I'm going to go to my second slide. How do I do that? Click. Next, there we go. I'm going to segue a little bit because I'm here to demystify a few things and perhaps not resolve the frustrations out there entirely. I don't think I have that power or the time tonight, but to give some explanation as to where we come from or where we often encounter frustrations. So the beautiful lectures that you've heard so far tonight have actually launched you further along the knowledge path of hormone therapy and menopause and premenopause than most physicians and gynecologists have been exposed to in their entire training of 4 years of medical school, 2 years more to become a family physician, 4 years of medical school, 5 years of obstetric gynecology residency. And I often say to my trainees, if you spend 1 day in my clinic, you will know more by the end of this day, not because I'm better than anybody else, but because I've spent over 20 years gathering this information, and I'm very, very excited to pass it along, that at the end of 1 day of training, they will have known more than most of us were exposed in 10 years of preparing to become a gynecologist. So gynecology is a very service-oriented residency program where we spend half of our time delivering babies, the other half learning how to become a great surgeon. And there is less than 10% of our program in 5 years that is actually geared towards training us for clinical work. And to give you an overview, in Canada, there are no requirement for gynecologists at the end of their 4 years of medical school and 5 years of residency to have undergone any training in the field of menopause. So there are very few of us who have sought it out. It may have been my maturity when I went to medical school that interested me and sent me in the pursuit of this information, but it is a rarity. In Canada, and I was reflecting on this last night before this presentation, I can probably think of 10 to 15 gynecologists across the country who have either become experts by choice and focused their practice on menopause and hormone therapy, or have received some extra training in the form of informal fellowships. And then when I was reflecting on that last night, I also reminded myself that half of them have retired in the last few years, and probably another third of them are on their way to retirement in the next few years. So that leaves a handful of gynecologists across Canada to handle the perimenopause and the menopause of all women. And we are not by design experts in the field at all. We wish to help, we mean well, but we've received the basics from our preceptors if we happen to see patients with menopausal concerns in our clinic. So I just want to do a little bit of vernacular. I do this with my patients. I find that very important because, again, in the last 18 years, this whole world out there has become very confusing, out of frustration that I absolutely appreciate and understand. A lot of our patients come and request natural hormones. And I'm not going to use the very quote that I usually tell them in my clinic, but basically natural simply means that something has not been unadult or adulterated. And in the world of hormones, we would have to go back and munch on soya, munch on wild yam from Mexico to get the extracts we need. And it would take a lot of work and a lot of yam and a lot of soya for us to achieve a certain level. So I tell my patients a little sarcastically, natural is a carrot that you've gathered from your garden. That's it, that's all. And nowadays we can pretty much question the natural out of the carrot that might have been exposed to pesticides, insecticides, the pollution in the air, and so on and so on. The very simple definition of synthetic that have almost now become to mean poison and toxic simply means that something has been manipulated, something has been extracted, and in the world of medicine and pharmaceuticals and hormone therapy, to make it into something concentrated that has a route of delivery that will make it efficient. It does not mean poison. All of the hormone therapies that we have nowadays are extracted from natural products. They have been synthesized so that women can easily apply, have an efficacious route of delivery, and get what they need out of those hormones. The word bioidentical was basically invented, created, again, out of the frustration of the 2002 era, because women basically understood and wanted, out of frustration or everything else, something that was plant-based, something that they had been told existed in nature that mimicked and matched as close as possible the molecular structure of the hormones that we make from our own ovaries, for that matter. The word bioidentical does not have a medical definition, and it will usually stump the physicians you approach with that word, as they will not have been educated, they will not understand the concept, and they've often been told by people they trained with that this was just poison to be avoided because it did not have any validation in science. So we'll come back to this in one moment. And finally, compound. Well, what I have to say is until 1965 in North America and pretty much around the world, every medication we took was compounded. There were no branded medications and drugs out there. You went to your apothecary, they prepared something for you that was measured, that had an appropriate route of delivery and so on. Nowadays, with the big pharma, the trust of which we also lost through that study in 2002 because the hormones that were being used were from big pharma. And understandably enough, we mistrusted big pharma, medicine, conventional training, and so on from that moment on. Compound drugs are available from specialized pharmacists. They are using, by definition, bioidentical and natural substrates to create more custom-made than what a big pharma can do. Some hormone therapy or other medications, by the way, that can be well absorbed, that have the efficacy. The truth is at the end, and I'm not making this up, I'm not inventing anything, in Canada and in the United States, the FDA and Health Canada do not have legislation over compound preparations by a specialized pharmacist. The FDA and Health Canada are responsible for putting out safety data and legislation around medication that has been created, manufactured in the big pharma industry that fall under the drug category. And to this day, the compound medication that is made in the specialty pharmacy falls under nutrition and will not be submitted to this. And that, I think, is one of the root cause of the mistrust that and a lot of miscommunication and misunderstanding of what has happened between one camp and the other since the big study exploded on us. So we have to understand, and I think it's going to be very useful to understand the language where it comes from. Very, very quickly, we have been prescribing bioidentical hormone therapy in Canada since 1986. The first patch that came out that contained 17 beta estradiol was Vivel. It's a transdermal patch. Not all of the products you see on the screen are available in Canada. Most are. Most are displaying the 17 beta estradiol, which is the molecule that your ovary makes, which is the more potent estrogen that we make in our body, in a sense, the one that is referred to as bioidentical. And as you can quickly see, many, many products have been available out there that no prescribing physician even realizes fall in the category of bioidentical. And at the very bottom, one of my favorite to prescribe, and I think we've had lovely conversations about this tonight as well, I'm a huge proponent of progesterone. I use it for so many different reasons, starting with PMS and perimenopausal symptoms and anxiety and sleep issues and so on, night sweats. There is a gigantic center in our brain where center of sleep, center of mood, center of anxiety are regulated, and it is absolutely dependent on progesterone to do well. And this is why the molecule that is not in peanut oil anymore, that is extracted from a wild Mexican yam, which is bioidentical and the only product in the world, is actually the source of the progesterone that has a great affinity with our brain. And I'm also a huge proponent of prescribing it to women who don't even have a uterus anymore, because I tell them that it's not because their uterus is in a jar that they don't have a brain that could benefit from the beneficial effects of progesterone for many of us. Just a very quick last word.
We're gonna jump in, Dr. Gamache, because we're running out of time. I've got questions for you that we're going to have at the end.
Excellent.
So I think we're gonna pass the baton to Dr. Jennifer Beecker now.
Perfect.
Sorry.
No, not at all. Not at all. I anticipated that.
So much great content, and you really helped unpack some of the myths and misunderstandings around a very, very large topic. So thank you. And Dr. Beecker?
Hi, yeah, nice to see everybody. I have host disabled screen sharing as well. So Nour, if you could just open me up, that'd be great.
Hi, Dr. Beecker, you should be able to share right this moment.
Okay, let me just see if that works now. I think that's working. Yeah. And how's that?
Almost. Yep, you're there.
Everybody's there. Great. Welcome, everybody. Thanks for hanging in. It's such a pleasure to be with all of these amazing panelists. I'm learning lots tonight. I'm going to shift gears a tiny bit and talk specifically about our skin. Loving the skin we're in. We're not 20 anymore, but who wants to be 20? We want to be the best possible version of ourselves at the age that we're at. So we'll talk a little bit about things we can do to help us along. So common questions I get in my practice all the time. The number one is definitely dryness around menopause, even perimenopause. The skin becomes extremely dry. So we'll talk about why that is and what you can do about it. Also sagging, loss of firmness, tone of the skin, the crepiness, especially under the eyes, and also more sensitive skin, more easily irritated, more rashes, more acne, more rosacea around perimenopause, menopause, and a little bit after as well. So when people ask me, why is my skin so dry? Boy, there's a lot of answers to that. So one, as we hit around 50, there's a decreased production of sebum or oil in the skin. So right away, we don't have natural moisturizer there. The pH changes, and that's really important with how our skin functions. An example of pH change would be an eczema. Patients with eczema have a very high pH, and some of these changes happen just with menopause. So it makes the skin barrier, as we call it, very fragile, very open to insult and injury, and rough and dry. And a big one is the loss of hyaluronic acid. So hyaluronic acid is what's called hygroscopic. It's a naturally occurring substance in your dermis, and it's the thing that gives you turgor in your skin. It kind of provides structure and moisture. It absorbs water. It holds onto water 1,000 times its weight. So it's almost like a molecular sponge or a water magnet. So it kind of puffs up our skin and makes it look really rich and kind of very young and vibrant. But as we lose this, the skin gets a little bit rougher, a little bit duller. It doesn't have that same turgor. So this starts happening even after 30. We lose about 1% of our hyaluronic acid after the age 30, so 10% a decade. And then as we get on, it gets more crepier, a little bit more of those fine lines and volume loss. So these are all things that contribute to why skin gets dry at this time. So what do we do about it? Well, first of all, I'm a big fan in dermatology of keep things simple. I like people to stay away from fragrances or things with a lot of heavy preservatives. We want a gentle fragrance-free cleanser on the face. If you're wearing makeup at the end of the day, wash it off with something that's not a soap, very gentle, or even micellar water. So sometimes people even have to just use plain water if their skin is really sensitive. And this is especially on the body. So on the body, really the only bits that get dirty are our armpits, our groin, and our feet. We really don't need a soap or a cleanser anywhere else unless you've been working in the garden. So those areas just get more and more dry the more soap you put on them. So just be conscious of that. Then you want to moisturize immediately after cleansing your skin. So freshly cleansed skin, you put a moisturizer on right away when the skin is still damp. So really simple. This is all basic stuff, but makes a huge difference. And then if you're really dry, you might consider a booster or a serum that has hyaluronic acid before your moisturizer. So a lot of these boosters are very water light, very light texture. They soak in very easily. They feel great on your skin and give you that little boost of hyaluronic acid that your skin is missing as it drops. And then also moisturizers with emollients and humectants both. So we talked about humectants already. One is hyaluronic acid. There's other like glycerin. Again, these attract, pull in water into the skin. And then the emollients lock in that moisture. So things that are more creamier or oilier and kind of leave a layer a little bit on top of the skin to lock everything in. So that's what works. So it's simple. Gentle cleanser, immediately put on a moisturizer. If you're really dry, consider the hyaluronic acid serum or booster before. Very simple. So what else? Everybody says that's it. Whenever I tell patients that, that's it. Don't I need some special stuff and a big routine and what happens? And then I always say, well, yeah, there's 3 more things. One is sun protection. The second is sun protection. And the third would be sun protection. So I don't know if you've heard about the exposome. The exposome's talking about external factors and also some internal factors that can influence our skin. Pollution, UV, hormones, all of these things kind of influence our lives and our aging and our health. So we can't do a lot about our genes and our internal parts like inside, but we can do a lot about the external factors. So sun and UV damage is something we can absolutely do something about. I love this image of this woman because it really shows even how much sun you get through a window. So if you look at the right side of her face, this woman worked beside a window for 30 years with her left side of the face beside the window. So if you look at the left side versus the right side, it's easy to tell which side was next to the window. So UVA coming through that window for 30 years is what's aged that side of her face. That's it. Everything else on the right is her. It's time, it's genes, it's age, it's things she can't control, but there's lots you can control. So sun protection, sun protection, sun protection. So what is that? Sunscreen, obviously, every morning, absolutely, if you're going outside. But if you're inside near the window, just think of this picture. You may want to use a sunscreen as well. I certainly wear a sunscreen every day. Minimum 30. If you're going out in the summer and if you're fair, consider a higher number. If you're darker skinned, you still need sun protection. You can get brown spots and other signs of aging. All those brown sunspots, it's all sun. So think about that. And other questions I get, if the skin is looking dull, how can I deal with that? So I'm moisturizing like crazy, it still looks dull. That's when you consider additives such as glycolic acid or retinol or retinoic acid. Retinoic acid is famous for its ability to stimulate collagen, but also exfoliation and cell renewal. So it's really a great additive if you need to add something. So you would do that in your moisturizer typically. And then sagging skin. Again, this is a really tough one because we lose 30% of our collagen in the first years of menopause and then 2% per year in the next 10 years. So, you know, it's a tough statistic to wrangle with, but this is why we're getting hollowness and loss of kind of the fat pads under the eyes and the jowls and all these things that we hate to see. Again, retinol or retinoic acid can help if you have that in your moisturizer, stimulate collagen. And then there's also some, of course, non-surgical options, injectables and things that can help with that as well. What about all these rashes, acne, rosacea, irritated skin, all these new things that happen around menopause? Well, again, it's a keep it simple. So the same gentle products you would use. So if you're getting acne, rosacea, new rashes, avoid drying products. You don't want to use the acne treatments, the over-the-counter treatments that are aimed at teenage skin. That's usually much oilier. We've lost a lot of sebum, a lot of that oil. So that will make things worse. If your skin is very dry, acne and rosacea just get worse. So avoid drying products. There are a lot of products that are very geared to keep the pH neutral. Some with salicylic acid would be fine for acne if they don't feel harsh on your skin. You have to try it out. Usually they're geared more towards mature skin. If it's in that kind of line, that would help. And then if that's not working, you're doing gentle products, you're avoiding drying products, you're doing basic skincare, that's good. Then you might have to see a dermatologist because sometimes we just need to deal with that hormonal level of issue that you've heard about so much earlier tonight from everybody. Sometimes we need some hormone-based treatments to help you. And lastly, there are some non-surgical options. Like we said, there's injectable hyaluronic acid. That's something we get asked about a lot. Sometimes when people have a lot of laxity and sagging, it can do a lot for people's confidence to help them. And that's it. Thank you. I tried to make up some time. I hope that helped.
Thanks, Dr. Beecker. That was amazing as always. Do you want to stop sharing your screen? I'll just, I think we'll open up the questions to the entire panel. Awesome. Okay, so Dr. Beecker, one question, and it's a common one, is extreme itchiness especially on arms and legs, and especially at night. Any insights for this participant?
Most of the time that is dryness and over cleansing. So again, make sure you're not using soap in the shower on your legs and arms. They absolutely don't need soap. Make sure as soon as you're getting out, you're getting a nice heavy emollient moisturizer with some humectants twice a day and then before bed. If you're doing all those things and you're still itchy, watch the temperature of your room, because anything warm is going to make you more itchy. So turn down the temperature. You may want to get a humidifier if it's more in the winter, because again, that contributes to dryness. A humidifier can help as well. Some products may have a little bit of a cooling sensation. There's some menthol in them. That's not a bad idea. If you have an intense area that's very itchy in the short term, sometimes an ice pack helps. If you're still itchy despite that, then I do think you should see a dermatologist or your family doctor first, just to make sure there's not another reason for that. Sometimes very low level atopic dermatitis, which is a type of eczema, can express just with itch first before a rash. Other things like infestations with scabies can make people itchy. So there's lots of other things medically, but usually in most women at perimenopause, menopause, and beyond, it's usually dryness and just over cleansing. So try and under cleanse, over moisturize.
Okay, that's a really good point. And another thing that we often hear is that women will say, I haven't changed anything. I've been doing the same thing my entire life, but now I'm experiencing redness, or now I'm experiencing acne for the first time in my life. And do you have a message for us in terms of understanding that there actually is maybe a need for us to change it up?
Yeah, there's a couple of things behind that. So one is our skin is changing. We have less oil, we have more needs. We need more humectants, more emollients than we did when we were younger. Many women, when they're younger, don't need a moisturizer at all if they don't over cleanse. So we need gentler cleansers, heavier moisturizers. But the other thing to keep in mind, if you're really reacting to products and they're irritating you, is I always joke with patients that the companies don't have to ask your permission to change their ingredients. So they can still call a product the same thing and put something new in it. So sometimes you're actually reacting to something new, like a new fragrance or a new preservative that's been put in there as well. So it's a combination. Our skin has different needs, but always think about the fact that there could be a change in the product and there's something new that you're reacting to.
That's great advice. Thank you. And last time we spoke, you really gave me more insight into hyaluronic acid. So I'm wondering if you could speak to that. I think many of our members don't even understand that it's something our bodies produce naturally.
Yeah, so hyaluronic acid, saying it too many times tonight.
It's late.
Yeah, it's getting late out here. It's how I describe it is like a sugar that wraps around collagen. So it's integrated in all of our skin around collagen, and it draws in water. So the reason why people use hyaluronic acid to inject is for the same reason. When people use fillers, it puffs up with water. It's the same idea. So it pulls in 1,000 times its weight in water anywhere it is. And because we lose it, we can actually add it back on the surface of the skin. There's been a lot of research into the right molecular weight to have hyaluronic acid reabsorb into the skin and then draw water back in. So putting on a lightweight serum, or some people call them boosters, under your moisturizer is a great way, because it literally will suck the water down into your skin, and then moisturizer over top, it just keeps it in. So if you have a moisturizer with both those things in it, a moisturizer with hyaluronic acid, it's a great combination.
That's awesome. Thank you. And I just want to call everyone's attention to the fact that it's 7 p.m. here on the left coast, and it's getting really late if you're on the other side of the country. So we are willing to stay for a couple more minutes. If you are, I see still a few hundred of you on the call. And so before you dart off and go to bed, I do want to thank you so much for putting yourself at the top of your to-do list tonight. There will be a recording that's sent out to you in a day or so. Watch it, rewatch it, share it with your friends. And we're going to stay around, and I'm going to do one more question with each of our experts before we say goodnight. So Dr. Gamache, thank you so much. We're getting lots of comments about the insights that you were able to provide with for us tonight, and for sort of breaking down some of the historical challenges that women have been up against. But the question, you're gonna have to unmute your microphone. The question and content that we didn't have a chance to get to that I really want to leave our participants with is understanding what are some of the common reasons a woman would be referred to a gynecologist? And it's going to be different for our Canadian listeners versus US. So can you explain that for us?
Absolutely. Thank you for the brilliant question and for reminding me as well. The gynecologist will be very well equipped to deal with issues pertaining to irregular bleeding. So I think that Dr. Kara alluded to this very well. There's a lot of changes hormonally that happens as early as the late 30s that will precipitate irregular cycles, that will make periods become heavier, last longer, occur more often, be more painful. This is very commonly where we see women, if they had not before, or they will worsen, situations with endometriosis, adenomyosis, fibroids, and polyps. And I'm not going to go into defining all of this, but all of the very, very common causes of excessive bleeding in early perimenopause, again, as early as the late 30s. And this is very much because although we revere estrogen, and excess, relatively speaking, occurs because of the natural deficiency in progesterone, and we end up with an imbalance that is favoring estrogen, and everything in the uterus feeds off estrogen. The lining gets thicker, the fibroids grow, the polyps grow, and they may cause irregular bleeding and all of these changes. This is when the gynecologist comes in. The excessive bleeding also needs to be addressed. There's a much greater proportion or risk of women who can actually develop when they're soldiering on and they think that this is par for the course in perimenopause, and they're bleeding excessively and they're going to tough it out until menopause, and they are not seeking help, are actually at risk of developing precancers or cancers of the uterus. Is actually much more common in the perimenopausal age range because of the relatively excessive estrogen compared to the protective progesterone. So these would be excellent reasons. Lots and lots of things can be handled by the nurse practitioner, the family physician. I want to remind every woman that if they are sexually active with somebody who is producing sperm, that they are at risk of a pregnancy until the very last period of their lives. And that's when I pull out my card and say, would you like to meet my 53-year-old with a pregnancy, my 51-year-old with a set of twins? And I can't even count the number of 49-year-old women who have been pregnant, not under my care, but came to me after a horrendous history and event. So I would say that these are usually the focus of the gynecological world, and very, very good reason for being referred.
Thank you very much. And thank you so much for the birth control reminder. I often get asked by women, how will I know when I'm reached menopause? And I'm like, well, do you really need to know? You don't need to know unless you're making a birth control decision. So yes, thank you. Yes. I'm going to use that segue to come back to Dr. Kara, because we had a question after your presentation about from a woman who has been prescribed the birth control pill, and she accepted the prescription and she went home, but then she got home and realized it wasn't really aligned with what her values were at this point in her life. And she wants to know what a naturopathic doctor would recommend. And you need to unmute, please.
Okay. Shirley, did she say why she was prescribed it? Was it for perimenopause?
For perimenopause experiences. bleeding, mood changes, sleep.
Okay. So that one's that one's a catch-22. You know what? It can, for some women who really are struggling, you know, there's always a time and a place for any medication. And if that's the right one for her and it helps her feel better, you know, that's totally okay. I worry that sometimes when we're using the birth control pill, we're kind of covering up those natural hormone production. And I really talked today about the benefits of our own hormones. And I almost said in there, it's like we prepare for retirement with like RRSPs and gaining, you know, putting into our pension. And that's what every single natural menstrual cycle is doing. It's kind of like banking health and using those natural hormones in order to, you know, kind of save for menopause. So it wouldn't be my preferred option. It might be the right one for her. I definitely don't have enough information. She might want to ask her doctor more about using oral micronized progesterone instead to control some of those symptoms. And then I might use a whole bunch of other naturopathic things in my toolkit.
Thank you. We could do a whole evening just on the pill and why not. So I have quite a few questions coming through for you, Dr. Beecker, after your presentation. And I just want to remind everyone that I will be taking the questions and responding to all of them. So if we didn't have a chance to get to yours, you will get a response from us, and we'll be hosting a live on Sunday, October 18th, which is World Menopause Day, where you can come and you can ask the other questions that you may have had, such as where can I find a practitioner in my area and so on. So Dr. Beecker, if you could unmute. We have an attendee who wants to know if skin tags are the result of hormone imbalance.
Not typically, actually. Skin tags can happen at any age, but we do see them over time just from areas of friction. Skin tags are mainly from friction, so people often get them around the neck or in the groin. It's just areas of rubbing. You know, I guess age could be a factor in that, you know, we have more years of rubbing, but it's not really related to hormones per se.
Okay, thank you. I think that's something that we all don't think about until one day it just appears, and then we're not sure if it's a concern that we should take action on. So that's great. Okay, this is the final one, Dr. Pawa, and it's not even a question. It's just, can you please share with us a message around stress and taking care of our cortisol, particularly in this time of a world pandemic?
Yes, you're right. It's so prevalent right now, and I speak to patients every day. And I would say the most important thing is to realize about whether you're reacting or responding. All that stuff out there is outside of our control, whether we get COVID, whether there's going to be a vaccine, whether we go back to work. We don't know. There's so much uncertainty. So go and look at what you can control. And what you can control is your breath. And it sounds so simple. You think the breath, like that's it. But there's a huge book actually written just on the breath. And what it shows is that, you know, we don't have to think about breathing. It's automatic. Our autonomic nervous system just kicks in, but we can control how we breathe. And when we do that, then that resets the nervous system. It calms your system down so that your mind is more calm. You make better decisions and better choices. So you end up responding and not reacting. So that would be my biggest advice. Just step back and say, you know what, we got this. Don't entertain fear. Come at the same circumstances with trust and use your breath. BMW.
Thank you. That's an amazing message for us to close such an incredible night of learning. On behalf of all menopause chicks and myself, thank you so much for saying yes to us tonight. And thank you to all our attendees for putting your own name at the top of your to-do list. I am now going to pass it back to Nour for our closing comments.
Thank you so much, Shirley. So first of all, I would like to thank you for moderating this this webinar tonight. I think that all of the information, personally, I learned so much, and I really appreciate the fact that you have been working with us and asking the questions, making the links with all of our experts. Which leads me to thank our experts tonight. I really want to thank you, Dr. Beecker, Dr. Pawa, Dr. Dionsio, Dr. Gamache. Thank you so much for sharing your knowledge and expertise with us, and for really helping us kickstart this webinar in celebration of Menopause Month. I would just like to remind everyone to respond to the survey for a chance to win a big full Vichy Neovariol gift basket. And for all of the questions that are directed to Vichy in terms of product recommendation, please DM us on our social media account, Vichy Canada, and we will make sure to answer all of your questions. Or if you would like to post them to Shirley, and she will transmit the question to us and we will answer. As for the recording, Shirley, you announced that you will be posting the recording, but also I would like to invite you all to follow us on Vichy Canada's Instagram page, where we will be announcing where we will be posting the video as well. So thank you all, of course, for joining us, for hanging in there for 2 hours and 10 minutes. We really appreciate it, and we hope that this information was helpful and that we can continue the conversation on menopause for the years to come. Thank you all very much.
Thank you. Thanks
Thank
for
you,
having us.
Nour. Thanks, everyone.
Thank you, everybody.
Everyone.
Night.
Thank you.
Good night. Thanks, everyone.